Good morning, everyone. Let's start with today's topic, that is balance assessment. Last class, we have already dealt with what is balance, what are the systems needed to maintain balance, what are the two main types of balance, that is static and dynamic. So, let's start with today's topic without further ado, that is balance assessment. Contents, types of balance, we have already dealt, that is static and dynamic. So, assessment for different types of balance is the main content today. Coming down to evaluation of balance. Balance is divided into three types depending on evaluation. We already know that there are two types of balance, static and dynamic. So hence definitely evaluation system for static and dynamic balance are different. Also, there's one more evaluation of balance type, that is static and dynamic together. This classification is based only whole and sole dependent on how you assess the balance. Whether you want to assess it only in static balance, only in dynamic, and when you combine that static and dynamic, both the system. Let's look at the test. Static is single limb stance, that is standing on one leg. Tandem stance, wherein your one foot is kept in front of the other foot such that the behind foot, the rear foot, the toes of the rear foot is touching the heel of the front foot. That is nothing but your tandem stance. Romberg test, foam and dome test, functional reach. I'll be dealing with these all specifically in the future slides. Static and dynamic will include timed up and go test, 30 seconds sit to stand test, star excursion test. Whereas in dynamic, it will just consist of dynamic gait index, functional gait assessment, 4 square step test, narrow corridor walk test. Today, specifically, we'll be dealing only with static balance and dynamic balance. In the further videos, I'll be dealing with static and dynamic balance assessment together with few more tests. Coming down to static balance. See, when we talk about static balance, I already told there are four main: single limb stance, tandem stance, Romberg test, and functional reach. So we'll look at one by one. This is how single limb stance is done, and the progression is with the support, without support, eyes open and eyes closed. So there are four types of single limb stance: with support, without support, eyes open and eyes closed. Look at how the model is doing. Single limb stance is performed when a patient is asked to stand on one single leg with observation of the other leg, whether he's maintaining at the same place at 90-degree hip knee flexion or not. This is what you have to assess in single limb stance. This is very important for balance assessment, especially of proprioception when we are doing without support and eyes closed. If we are doing for with support and eyes open, then it will be for visual, and with support the proprioception will be cut down, so it will be for vision or auditory as well. Now coming down to the second one, that is tandem stance. Look at the video. Again, it is divided into four types. She is doing eyes closed, single limb stance. With the support, single limb stance. She's holding a table, and with support she's doing single limb stance, and without support, single limb stance. This is without support. This is how the progression should be: with support, without support, eyes open and eyes closed. Coming down to tandem stance, this is how I described, and she's doing the same thing. The rear leg toes are touching the front leg heel. So this is also again done the same thing: with support, without support, eyes open and eyes closed. Coming down to Romberg's test. Romberg's test, when she's just touching the 2 feet together, not even making a V. Their feet are touched together completely, whereas the patient is asked, or the model is asked, to do eye closing. If this position, sorry to start it again, if this position is maintained for around 30 to 60 seconds, some books tell 30 seconds and some books tell 60 seconds. So if you're writing the seconds, please mention the reference of the book which you have referred, whether it is 30 seconds or 60 seconds. So if that position is maintained, then definitely her proprioception and auditory are the best, because visual is closed. She's closing her eye. That is what is Romberg test. There's one more test known as modified Romberg test, wherein the patient is asked to do the same test Especially there are three types of modification. One is wherein she is going to do the tandem stance, one is wherein she is going to do the single limb stance, and one with single limb stance and her hands are across the chest and away from the chest. These are the three modifications of Romberg test. So let's look at the video. Coming down to the functional reach, that is the last one. So imagine this is a bottle. I'm just giving you a brief example of what is functional reach test. This is not how we do it with the patient. This is just an example. The patient is instructed to take up the bottle in one hand, not even moving from that place. That is how the static position is maintained by the patient. He just has to take up the bottle. You have to observe, you being a therapist has to observe that whether he is going to take a step ahead on telling, or bend his trunk more awkwardly, or in fact increasing the flexion degree and not using his hand. These are all the things to observe how the functional reach is done. Ideally, when we are talking about patient, ideally when we are talking about patient, those are the things which you are going to observe. And when you are dealing the same thing, functional reach test, when you are dealing the same thing when you are with the patient, ideally you have to make him a sit, and you have to give your hand to touch in front, sides, not back, in front, sides, and having a rotatory movement of the trunk. This is a static balance test. You can do also functional reach test in dynamic balance, wherein your progression of static balanced functional reach test, you have to make a patient sit on the Bobath ball. I couldn't get the video because there was no Bobath ball available that time, so sorry for that. Same thing is done again. The therapist is holding his hand in front, sides, and you have to ask the patient to rotate the trunk and touch the opposite hand. Coming down to dynamic gait index. This is how dynamic gait index scale is performed. These are the dynamic tests. I have just started with the dynamic test. First one, in the dynamic gait index, the first point tells gait on level surface. That means you are going to ask the patient to walk down on the leveled surface. You cannot ask the patient to walk down, however the surface is unleveled. If the surface is unleveled, do not take the first step of dynamic gait index. When we are talking about any index, please follow step by step. Do not just directly jump to the second point and then come back to the first point. The first point is gait on level surface. What are you going to observe in the gait on level surface? All things you need to observe. Look at the video. You need to observe how she is walking. Whether the foot is equidistant, if the right or left, whichever is in front. She is using her arms. Just look at this. She is using the arm swing or not. Yeah, she has reduced arm swing, and whether her head on body and alignment is present, so that visual and auditory reflexes are acting properly and her joints are moving symmetrically with the other leg. This is what you are going to observe on gait on level surface. So this is how it will look on the video. So the second point will be gait with speed change. This is very important when we are talking about proprioception. You have to ask the patient to immediately change the speed once she is walking with a regular speed. Either let it be faster or let it be slower. So the systems in target for gait with speed change mainly is your proprioception of the muscles. Second one will be gait with horizontal head turn. Here your visual and auditory are very important. All you need to ask the patient to do is turn on right side after certain distance walking, and then turn on left side. So this is very important for visual and auditory reflex to be active. If it is inactive or disturbed, then she cannot do it. Same thing, vertical head turns. Look up and look down while walking, not doing static. So these were the 4 points of dynamic gait index. Coming down to the fifth point, gait with pivot turn. Ask the patient to walk forward, suddenly turn and walk in the opposite direction. This is how it will look. The systems needed are all three, proprioceptor and auditory and visual, because she is suddenly turning her body. Coming to the sixth point. sorry, that is your step over obstacle and step around the obstacle. So I have kept three obstacle. Ideally we need to use the cone in the clinical aspect, in the clinical scenario, but I didn't have cone, so I have just placed one helmet and two bottles. The obstacle should be 6 meter away from her standing position. The first one, on just I'll be just look at the sixth point, that is your step over obstacle. The obstacle should be 6 meter away from the patient should be 6 meter away from the obstacle. So you have to tell the patient to start walking, and you have to tell the patient to cross over the obstacle. That is, her leg should come above the obstacle. The obstacle height is very important. Ideally, the obstacle height should not be more than 12 inches, because that is your ideal height of the step. Coming down to the important point, what to observe when you're going to go for the sixth point in dynamic gait index. What are the things which you're going to observe? Whether you have to not only ask the patient to do it with one single leg. No, because when we are taking this dynamic gait index in stroke patient, we need to assess both the legs, the affected and the unaffected. So ideally you have to tell the patient to step over an obstacle with the right foot or whichever foot she feels comfortable with the first time, and then go back to the first point and step it over again using the other leg. While stepping over, whether she is going to increase the arm span, that is, whether she is going to reach out to any help. That is also one important thing which you need to observe. So let's look at the point 6, that is stepping over obstacle. So this is a patient is normal. She look at the foot. She is absolutely fine. Her foot is rightly lifted up when she is coming nearby to the obstacle, and then she is crossing over it and walking ahead. So this is your 6th point, stepping over obstacle. Coming now to the 7th point, that is step around the obstacle. So here I have not taken the going back and using the other leg. I have just jumped to the 7th point. You shouldn't continue like this. Together 6 and 7, they are totally different indices in the dynamic gait index. So 7th point is stepping around the obstacle. Again, from the starting position 6 meter away, the first obstacle is kept. The second obstacle is kept 6 meter away from the first obstacle. Ask the patient to just normally walk from the starting position, walk around the obstacle in a zigzag manner. On the first attempt, just start keeping one obstacle. Do not even consider dynamic gait index that time. After he realizes he has to walk around, first comes over the obstacle, and then he should realize that he has to just walk around the obstacle. If the cerebellum is affected, he cannot do that. Static and dynamic balance is gone. So you have to train the patient to walk around the obstacle in a straight in a curved manner. After achieving that, you can let the patient to walk zigzag manner with stepping around of obstacle with minimum of 2, which is needed in dynamic gait index. So this is how the patient will look when she's going for the 7th step, that is stepping around the obstacle. What you need to observe again, for the arm span for grasping something, or asking for help or feeling dizzy, and if she is the stroke patient or if he is the stroke patient, whether the flexor or extensor synergy is activated, either of upper extremity or lower extremity. Those are the signs to be observed. Coming down to the last point, I think, stepping. This is the last point of dynamic gait index. So generally ask the patient to know normal step up and step down, complete the steps. All you need to observe is whether she is holding the rails and what are the synergy pattern if the person is stroke attacked or stroke survivor, and the amount of time spent by each foot on the front step on the rear step, and how is her balance, whether she's looking down at the step and walking up and climbing down, or she's normally having a gaze in front. So all are important. Coming down to functional gait assessment. First 6 steps of dynamic gait index and functional gait assessment are same. After that, only 3 steps are different. The last step of functional gait assessment is the stepping step, which is similar to dynamic gait index, that is your DGI. Coming down to the 3 different steps of functional gait assessment. The first one is after 6 steps of dynamic gait index, this is the 7th one. Gait with narrow base of support. Ask the patient to do, how we taught in Romberg test, ask the patient to do the same thing, that is feet together. One addition step over here is eyes closed, feet together. One addition step is crossing over the hands around the chest. This is done because ideally gait involves arm swing. But when we are talking about narrow base, if the patient is balance affected, he tends to stretch out his arms to, grasp something, to grab someone, to be supportive, to be, stable. So that is avoided in this very important first differentiating factor between functional gait assessment and dynamic gait index. So you have to tell the patient to, first close the feet, that is, place your feet closer, then cross the hands against the chest, close eyes and walk. Look at how she walks. I will not tell it. Look at how she walks. Close the hands and she walks in a tandem gait. You can either ask the patient to do, close the eyes and walk in this fashion, or you can just tell the patient to do, normal walking in this fashion. Closing the eye will be good in a progressive manner. Do not just tell the patient in the first day, on the first day only, gait with narrow base with closed eye. You cannot tell that. The patient will run away from the clinic. So while doing this, observe her head position. She is bending down, which she shouldn't. She should be looking in front, and the tandem gait, whether it's proper, and this hand cross, whether she is opening up the hand cross. So coming down to the next one, that is your gait with eyes closed. So this is a split up part of the last one. Here normally a patient is just to walk normal, no reduced base of support, or not even hand closing the body or embracing the body. It is just closing the eye and walking. So look, the patient is asked to close the eye and walking. Look at the gait speed, and she's swaying a lot when you compare it with a normal gait. So this is what you have to observe in the patient as well. Coming down to the last point, which is differentiating among functional gait assessment and dynamic gait index, that is your ambulating backward. Ask the patient to do just walk backward. Ask her, sorry for this thing, ask, when she's doing this, observe how she's placing the feet. Whether it is first contact is the heel or the toes. Ideally, when you ask a patient, normal person, to walk backward, the first contact should be toes, not heel. So you have to observe that one, and you have to also observe whether she is going to, do the arm spanning technique, so that, she is trying to grab up something to be, more stable. So sorry again, this is how the video will look. Yeah. So she's actually doing first toe, then midfoot, and then the heel. This is the ideal way of walking backward. Coming down to this is a figure of 4-step test. This is totally different. This doesn't come in DGI, that is your dynamic gait index, or your functional gait assessment. This is a different one, figure of 4 test. 2 lines are drawn intersecting at a certain point, single middle point. Ask the patient to stand in one of the corner, and then ask her to, just move to every corners in one direction, reaching down to the same point, and then back in one more direction, reaching down the same point. Observe what leg she is going to use, which is a dominant leg, and tell her to repeat the same test with the non-dominant leg as well. Also ask whether look at her hands, whether they are stable beside the torso, or she's doing the arm spanning technique wherein she's going to grab up something. She might feel she's uncomfortable, she will fall down. Also look at her head and body on head alignment, whether the trunk is bending sideways or forward. So these are the things to concentrate. And also please, when you're taking down the figure of 4-step test, please make sure you do it on the 2 legs, that is dominant as well as non-dominant, that is affected and non-affected in the patient scenario, because the weight bearing is definitely reduced or increased on the affected, depending on the synergy actually. in the stroke cases. So for weight bearing purposes, you need to check it on affected as or unaffected. And if you guys are taking this test normally, then you cannot mention them as affected and unaffected extremity. You need to just mention that dominant and non-dominant. Look at the video. Ask the patient to do, stepping in all four corners, going back to the same corner. Do it in the reverse direction with the opposite leg. Okay, this is how the figure of four step test will look. So this was the end of the lecture. Let's meet you all in the next lecture. Thank you.